Good evening. Good evening. Welcome to the National Fellow Online Lecture Series. Today, we will be going over the MRI Series Lumbar Spine. Today, our guest speaker will be Dr. Olufade. So Dr. Olufade, one of my really great friends, is an associate professor. Congrats on that this year, this last past year, in the Department of Orthopedics at Emory University, who specializes in sports medicine and spine care. Has a particular interest in youth sports, active adult, ultrasound, regenerative medicine, and orthobiologics. His approach emphasizes non-surgical treatment for sports and orthopedic injuries, including ultrasound and fluoroscopic guided injections. Dr. Olufade is the head team physician for the Atlanta United Football Club and LOVB Volleyball. He also served as physician for various athletic teams, including the U.S. Soccer the U.S. Soccer Physicians Network, college, the College Park Skyhawk, and Emory University, and several local high schools as well. He's well versed in sports medicine. He's well loved and well liked, and has an amazing family. But truly, he's a scholar and a gentleman. So I'm going to go over to through a couple of logistics beforehand, and then I will turn it over to him to start the talk. So just so you know, the next lecture will be given Wednesday, March 25th, 2026 at 8:30. It will be Dr. Fredrickson and Dr. Olufade. It will be talking about the diagnosis, treatment, and prevention of bone stress injuries. Okay, so make sure if you're tuning into these that you don't miss that lecture as well. So these basically serve as adjunct to your own programmed education. This was started and able to supplement education throughout the nation and provide fellows with direct access to educational experiences with AMSSM members and invited guests in a variety of formats, and to assist in CAQ studying. So as far as our logistics, I want everybody to mute your device and turn off your video. Submit any questions through the chat, which I will peruse through to make sure that they're asked at the end of this lecture, and we will go based on that. And then after the program, please complete the evaluation sent to you at the end of the lecture. And just a reminder, as we all know, AMSSM conference in Seattle is coming up April 23rd to 29th. So at this time, I will turn it over to Dr. Olufade.
Thank you very much, Dr. Frank, for the introduction. Look forward to moderating the next Fellowship Online lecture series, which is actually on March 4th. That's next week, Wednesday at 8:30. So the topic I've been asked to speak on today, MRI of the lumbar spine. I think that's something that a lot of us see, and sometimes we are fearful or don't want to address it because of the complexity of the condition that we're dealing with. I will say the MRI of the lumbar spine is sometimes similar to a middle-aged person with multiple degenerative changes. And the question is, which one of the findings that you see really matters, or which one is given the symptoms, or which one is given the diagnosis? I will say a vast majority of the findings that we're going to go over might not be symptomatic. One of the last few slides will give some of the pearls in terms of what I look for in terms of what could be symptomatic when you're reviewing the MRI. In terms of my approach to looking at MRI, some folks will go with the A, B, C, D, E. One, A is for the alignments, B is looking at the bones, C is looking at the canal, checking for disc or foraminal stenosis or facet arthropathy, and E is to kind of look for everything else. I think it's important to have that pattern of search. As a result of that, you don't miss anything. Even though the scope of this topic is on lumbar spine, if you were looking at the cervical spine as well, too, you want to look at a few components, including the cranial cervical junction, and that's part of the everything else. That's part of the E that you should be looking at. I have numerous slides to kind of show today, but the goal is to kind of get a little bit more pattern recognition. The more you recognize the pattern, the more comfortable you feel when you're looking at this MRIs. So to get started, this is a basic lumbar axial view, starting from the anterior aspect to the posterior aspect. When you think about the vertebral, lumbar vertebra, you think about the anterior column, the medial column, as well as the posterior column. Anteriorly, you have the body. As you start getting to the middle column, anteriorly, you have the pedicle, and posterior, you have the lamina, which are the borders of the canal that you have, as well as posteriorly, you have the spinous process. I think having an idea of what this anatomy looks like, and when you translate it to look at MRI, it gives you a better understanding of what you're looking at. So basic nomenclature of MRIs, when you look at it, you look at the sagittal view and you look at the axial view. In some cases, you look at the axial oblique view that allows you to get a little bit more clarity on what's going on. When you have those views, you also have what we call a T1 view, T1 as well as T2. As most of us learned in medical school, the way to differentiate T1 and T2 is fat is usually bright in T1 and water is usually dark in T1, I'm sorry. As a result of that, the CSF fluid that you see around the canal will be dark. That's in contrast right here. That's in contrast with the T2, where you have the cerebrospinal fluid will be bright in nature. Another key component of this is to kind of look at the color of the vertebral bodies, which we'll discuss in a little bit. This is an axial view looking at the T1 and T2. When you look at the T1, usually it's difficult to differentiate between the nucleus pulposus and the annulofibrosis. So when you look at this first T1 view, it's a little bit homogeneous in nature versus when you look at the T2, the analogy of a jelly donut, gel in the middle, being in the nucleus pulposus, and the annulofibrosis being on the outside, which is the jelly. As you go posterior on on this axial T2, you have a better understanding of what the CSF looks like and what the canal looks like right this way. Versus when you look at the T1, you don't have a clear understanding of that. You could see some of the exudate nerves and transverse nerve that is present over here. And you could see some of the CSF that's present over here. Posteriorly, you see the facet joints, which are composed of multiple structures, including the ligamentum flavum. So just having an idea of what this looks like on this particular view. As you slide down, you could see a pedicular view or pedicular location. And that steric that's listed over here highlights the pedicle, just to kind of get an understanding of what it looks like. And as you go down, you start getting an orientation of where the nerve roots look at or where they're located. This particular axial view is for the L5-S1. And I often say this, just because somebody has a disc herniation of the L5 does not mean they have an L5 pathology. It could be an S1 pathology, and in rare cases, an L4 pathology. So the ample of times when we get referrals, I think it's just important to feel comfortable with this. So when you look at this, this is the S1 nerve root over here, and this is the exiting L5 nerve root. So depending if the pathology or disc herniation or stenosis is central versus lateral, it will be actually impinging on different nerve roots. So this is what the T1 looks like, and you could have an understanding of what the nerve roots looks like on the T2 on this particular image as well. So speaking of nerves, as we all know, we have 8 cervical nerve roots and 7 vertebral bodies. And as a result of that, as you get to the lower lumbar area, using the L5, for example, they exit below the L5 pedicle, versus if you're looking at the cervical spine, they actually exit above the vertebral body. So I think that's just one thing to kind of keep in mind. That way you have a better understanding. Meaning, for example, like I mentioned earlier, L5-S1 disease pathology or disc herniation can affect the L4, can affect the L5, or sometimes the S1 nerve roots. So back to in terms of the orientation, we mentioned the A, B, C, D, and E. This is kind of what I'll be discussing, having that protocol to be able to go over things. So let's start from the A, which is the alignment. Usually you see if somebody has a kyphotic posture, you see they have a flat back syndrome, you see they have straightening of the lumbar spine. Oftentimes there could be spondylolisthesis, which is the slippage of one vertebral body off the other. When you look at alignment, it allows you to kind of highlight to see this something called a compression fracture that's present. As you look a little bit closer to the vertebral body, you can now look at marrow signal changes. Is this something that's malignant versus benign? Is this something that's focal versus diffuse? Is this more of an end plate issue? Having this paradigm, having this mechanism in which you kind of go through this checks and balances and know what to look for will allow you not to miss too much when you're looking at it. So as I mentioned earlier, there are going to be several slides that we're going to be going through. Some of them I might skip a little bit and go a little bit faster. It's just more pattern recognition. That's why we have several slides. So the first one is a normal T1. When you look at the T1, the bone marrow is a little bit brighter. And so that's kind of what you will see right here. The disc is a little bit darker, and the fat, which is a little bit more posteriorly, that will be a little bit more increased signal and lighter. When you look at this, I'm going to refer to more of a post-gadolinium. I guess the closest technology to have with that is also called a stir image. So sometimes we're going to use that interchangeably, a post-gadolinium and a stir image, because they kind of have similar properties. So when we start looking at abnormality, if you think about a T1, fat is supposed to be bright. And the bone marrow is supposed to be bright as well, too, because it has some of the fat in it. When you look at this T1 image, you see that's a little bit darker. And that's a little bit concerning when you look at the T1 image. And because it's diffuse, you start calling it a question, why is a vertebral body on a T1 image this dark? Unfortunately, in this particular scenario, this came up with a diagnosis of leukemia just because of the abnormality. Oftentimes, you also look at a stir image, and if you look at a stir image and you kind of have a little bit of similar type of findings, that's kind of what makes you concerned that there might be something else going on. This is also another image we mentioned earlier on T1. The vertebral body is supposed to be bright, and it is in this scenario. But look at this T1 image and look at the sclerotic changes and end plate changes. They tend to be diffused through multiple vertebral body. So owning in a little bit to the vertebral quality in this particular scenario is myeloma. And lastly, but not the least, when you also look at this, that's the benefit of doing contrast. One of the common questions that I get is this: when should you get contrast with your MRI? What I often say is this: if you're looking for malignancy, you get with contrast. If you're looking for infection, you get with contrast. If surgery was done in the past couple of years, and some of the slides I'm going to be talking about in a few minutes. And if you're trying to differentiate between a scar tissue and a disc herniation that's new, those are the three instances when I will usually get contrast with my MRI. So lastly, but not the least, this is another finding of abnormal marrow changes with a diagnosis of Ewing sarcoma. I guess the point I'm trying to make is this: obviously, it's not our job to kind of diagnose this, but just be able to have some idea in terms of if something is bright on T1, and that is normal for the vertebral body, but it's been more dark on T1, and now you look at the T2. If you look at the T2 or the stir image, and you can see through some abnormalities in terms of what it looks like, you will have an high index of suspicion that there might be something going on. One of the common abnormalities that we see that's benign is actually vertebral hemangioma, which is just a collection of blood vessels that happens to be present. This is very common, and you see it in about 10 to 12% of the population, and they're often asymptomatic in nature. So vertebral hemangioma that you see a lot of times, they have no reason to give you pain. A couple of times they might be atypical in nature, and if they're atypical, that's one of the instances where you get a contrast with it to evaluate if it's benign or malignancy in nature. One of the characteristics of vertebral hemangioma is it's going to be hyper intense, bright on the T1 and T2. So when we look at the T1, we mentioned that the vertebral body should be bright, but look at what this looks like in comparison to this. And when you look at the T2, where the CSF fluid is white, you can see this increased over here. So this will be more consistent with hemangioma. I do see a good amount of compression fracture as well. So a lot of times there will be dark on both T1 and T2, if it's chronic in nature. But if it's acute in nature, you're going to see some increased signal changes, pretty much more white on this view. And that's the same thing that you will see on this third image. So just keeping in mind compression fractures, hemangiomas, as well as some of the malignancies are some of the things to look at in a vertebral body. Switching gears to spondylolisthesis. That's the slippage of one vertebral body in comparison to the next one. The grading usually is based on how much slip that you have. Grade 1 is 25%, grade 2 is 50%, grade 3 is 75%, grade 4, 75% to 100%. And if you have spondyloloptosis, which is greater than 100% slip, that will be considered grade 5. So these are schematics of what it will look like. So when we look on this particular image to my left, the superior one is anterior to this inferior one. So this will be a grade 1 anterolisthesis of L4 on L5. And that's kind of the same view you have here. This is grade 2. So if you look at this, when you count and look by percentages, this is about 25% and this is about 50%. So because there's a 50% slip of L5 on S1, that will be considered a grade 2 spondylolisthesis of L5 on S1. Moving forward, the newer technology actually allows you to see spondylolysis a little bit better. But this is kind of what it'll look like. And if you have a listhesis like you have over here, oftentimes there's a spondylolysis that's accompanying this or associated with this. I tell people if you have a pretzel, if you have a break here, it's a little bit unstable. And that's kind of the situation we're dealing with. And that's what results into spondylolisthesis. Now we'll move on to modic changes. And modic changes are type 1, 2, and 3. Type 1 is the one that's more associated with pathology and discomfort and pain, meaning type 2 and type 3 tends to be mostly asymptomatic in nature. One of the characteristics of that is in T1, you'll have more of a darker color versus in T2 will be more brighter color, which will be hyper intense. And the next couple of slides will show what that looks like. So looking at this, for example, when you look at the T1, get my cursor right here, it's a little bit darker versus when you go to a T2, it's a little bit brighter. And this would be some variation of what a stir image would look like, but this is more indicative of modic type 1 changes. Modic type 2, I think for board purposes, I remember doing residency, definitely remember getting a couple of these questions. Can't remember if it was during the SAEs or the board. But modic changes type 2, usually there will be hyperintense on T1 and T2, while type 3 will be a little bit hypointense. So more brighter on the type 2 and darker on type 3 on both T1 and T2 images. So what do they look like? Type 2, it's bright on the T1, as we could see right here, and it's bright on the T2. That's kind of how you identify the modic changes. There are some other clinical pictures where the modic changes are important, but for the sake of this, I think it's more for pattern recognition more than anything else. And this is also another T2 showing how the hyperintense discoloration at the end plates is very obvious. Now we're going to move on to, we discussed alignment, we discussed briefly the bone. Now we're going to talk about the canal. When we talk about the canal, the different structures to kind of highlight, we'll talk about the disc and we'll discuss the facets a little bit more. The nomenclature for disc varies from individuals to individuals and sometimes from organization to organization. We're going to lump this up into maybe more of the degenerative group, the inflammatory or infection, and we spoke a little bit about neoplasm, but we'll briefly discuss that a little bit more. So as you all know, the younger you are, your disc has more collagen, it has more proteoglycans, it has more hydration. As you get older, for whatsoever reason, it gets loss of water, loss of collagen, loss of some of the protein that's in it. And as a result of that, it will get a little bit darker in color. So this is what a normal sagittal view looks like. Once again, if you look at the T2, the CSF fluid is white, the disc is normal. When you look at the T1, just because of the color, you don't see the white on the disc as much because this is more of a T1. If you start looking at an abnormal disc, like we mentioned, loss of disc height and other things and collagen, what you start seeing is a desiccation of the disc. And as a result of that, it starts turning a little bit darker on T2. So you can see the transformation of this that goes into this. And oftentimes this is asymptomatic in nature. So one of the pearls to mention is just because you have a disc desiccation does not mean it gives you pain. Oftentimes it's actually asymptomatic in nature. You could have some congenital as well as some developmental variation due to other conditions, which I'm not going to go through in too much details, but understanding that there's a lot of other degenerative processes that you could have. I'll briefly discuss some of the intervertebral osteochondrosis in a few minutes. There's something called vacuum phenomena, meaning when you lose water, when you lose protein, when you lose collagen, in the vertebral body, there's actually the production of nitrogen gas. As a result of that, the production of nitrogen gas is actually more hypointense, meaning darker. So you actually will see a darker line, regardless of what imaging modality you're looking at an MRI or looking at an X-ray. And I'll show you those examples in a few minutes. So these are some of the degenerative process that you have. And the purpose of this slide is when you see this on MRI report, you just have an idea of what it is. Spondylosis deformans is when you have this osteophytic changes on the superior and inferior aspects of the end plate and the disc. Oftentimes the disc itself is not compromised at all. Versus this intervertebral osteochondrosis, it's more of a disc pathology and not as much of the end plate changes that I mentioned over here. And pretty much what I said just now is kind of explained in words over here. So this is what some of the discogenic pain will look like. So oftentimes, if you look at this disc desiccation, they're asymptomatic. But sometimes, if you look at this, they could be symptomatic. But I would say this, probably depending on what the age group is, you could have this narrowing of the disc and have no pain at all. So I think so when I get sent an MRI, sometimes this is good, but the physical examination and the history is as important, if not more important, than the MRI pictures that you're looking at. This is the vacuum phenomena changes that I was mentioning. So if you look at this hypo-intense structure that you have over here, that's the release of nitrogen that kind of magnifies the nature of the degenerative disc that you have. So we're going to go to some of the semantics of a disc bulge versus a disc herniation versus a disc extrusion versus a disc sequestration in a few minutes. So a normal disc, you could think about it, there's 4 quadrants. In general, if you have a bulging disc, the way to kind of think about it, it affects more than 50% of the circumference. Versus if you have a disc herniation, it tends to be more a quarter or more like this 25% of the pie. So disc bulge tends to be more greater than 50%. A disc herniation tends to be more 25% or less. So in this case, we have a symmetric disc bulge because you can see that some of the nucleus structure is kind of going a little bit wider than the structure of the disc itself. So that would be a symmetric bulging disc. What does it look like in MRI? This is probably some of the vacuum phenomena changes that's happening. And that's why it's a little bit darker right here. And you can see the widening all around over here. And that's what will be a disc bulge will look like because it's greater than about 50% of the circumference. When you look at this one, this is an annular tear. And I've seen majority of annular tear be asymptomatic, but there are few that could be symptomatic. Annular tear is when you have a separation of the fibers that's present in the annular fibrosis from the vertebral body. Oftentimes, they will show up on MRI as a hyperintense, more white structure, usually on the T2, but it can be darker and hypointense on T1. So this is what an annular tear will look like. Some elements of it here. and maybe a little bit of elements of it over here as well too. Understanding that it does not affect the nucleus pulposus that's in here, it's more of the annular fibrosis, which is the outside part that's it's affecting. A disc herniation, like I mentioned, you could divide that into a protrusion, extrusion, or sequestration. Usually, if it's a protrusion, the base that's attached to the disc tends to be wider compared to the apex, versus if it's a little bit more of an extrusion, the base is actually narrower compared to the apex. Versus if it's sequestration, usually what you have is you have the detachment of the disc material from the disc itself. And the next couple of slides will kind of highlight the protrusion versus an extrusion versus a sequestration in a few minutes. So this is what a herniation look like I mentioned earlier, usually less than 25% of the circumference of the disc. This is what an annular tear will look like, seeing that the nuclear pulposus is still intact. It's the fiber of the annular fibrosis that's having some pathology, versus a disc herniation where you can actually see the disc materials come out laterally or posteriorly, depending on the way you want to describe it. So once again, extrusion, it's narrower at the base and wider at the apex. And we'll show some of these pictures in a few minutes, like I mentioned. So looking at this, if you have this protrusion, wider at the base, narrower at the apex. Extrusion, narrower at the base, wider at the apex. And so those are the semantics of differentiating it. If you have a disc extrusion, is it always going to be there? Studies have shown that actually, if you have a disc extrusion like this, about 80% of them would actually shrink and get smaller with time. So just because you have this on MRI does not mean it's giving you a pain or it's a pain generator, but understand that sometimes in time, it actually could shrink and get smaller. So this is a broad-based disc herniation. As you can see, it's less than 50% of the circumference, but it's a little bit wider than the ones that I showed you a little bit earlier. This is a protrusion versus extrusion versus a sequestration. Not to belabor the point, when you look at a protrusion, it's wider here versus here. When you look at extrusion, usually it's wider a little bit distally versus proximally. Versus sequestration, you can see the detachments of the disc material from the native area where the disc came from. And so this is what a disc extrusion will look like over here. And this is what an annular tear will look like over here. So there's still another terminology that's often shown and seen on the MRI report, which is Schmoll's node. This is more of an intervertebral herniation. So literally the disc invaginates into the vertebral body. And so when you see those type of verbiage in your MRI, that's pretty much what it means. And oftentimes it's more indicative of more of a degenerate disc and not necessarily a pain generator. And so this is what a Schmoll's node will look like right here and right here that you see. Oftentimes it's a benign pathology that you don't have to necessarily worry about. And this is another schematic of it. So we're going to talk a little bit about disc pathologies and how it affects the nerve and what are the locations of the nerve that it's affecting. So when you have the canal, so far we've addressed A as the alignment, we've discussed kyphosis, we've discussed scoliosis. We've discussed B a little bit in terms of the marrow changes, malignancy versus benign. We discussed focal versus diffuse. We also spoke a little bit about canal, and we spent the last few slides discussing what the disc looks like. But now when we talk about the canal itself, there are other pathologies and etiologies that could result into that narrowing, including facets, ligamentum flavum, the listhesis. If you talk about the cervical spine, there's a few other verbiage, including uncinate process, that I'm not going to highlight as much, but that's what you look at when you look at the canal. So this is a disc herniation with central as well as lateral stenosis. So looking at this L5-S1 level, for example, this over here, you have the S1 nervures that are down here and the L5 that are here. So with a disc herniation, we could have somebody that have exclusive L5 pathology, or somebody that has exclusively S1 pathology, or somebody that has a combination of both. That exam, that history, the physical examination is what's going to allow you to deduce which one of the nerves have been affected. This is an L4 disc herniation that will affect the L4 nerve root as well as the L5 nerve roots. So when you look at this particular view, this is a paracentral. So oftentimes they'll call this the central. This is the lateral recess. This is the foramen. And this is the extraforamen over here. So depending on where that herniation is, sometimes the nerve that it gets affected matters. So it's important not to sometimes rely just on the report. Depending on the level of comfort, being able to kind of look through this and see what pathology is being affected. This is a little bit more comprehensive, but what this is showing is the facet with effusion, severe stenosis centrally, as well as foramen. And as a result of that, at the L4-5 level, this is impingement of the L4 nerve roots that we have over here. This is L3-4 extraforaminal stenosis that's happening. And that's kind of what you have laterally over here. And that will affect some of the nerves as well, too. So it's just more of a pattern recognition, like I'm mentioning. The goal is just to show a lot more slides. That way you're familiar with some of those pictures when you see it. So we'll talk about the other things that kind of affect the stenosis, like we mentioned earlier. The facets over here. So if you look at this particular picture, the canal is supposed to be a V structure like this. This is severely compromised, and it's because of the disc and the ligamentum flavum hypertrophy, as well as facetoarthropathy, that narrows this very well in comparison to some of the structures we looked at a little bit earlier. When you look at the sagittal view, there's a little bit of congenital stenosis, meaning there's just narrowing. If you look at this particular picture to some of the ones that we showed you earlier, you will see that the space is a little bit tighter. So if you now add this ligamentum flavor hypertrophy as well as facetoarthropathy, it significantly narrows the space at the L4-5 level that you have over here. So congenital stenosis with acquired stenosis for facetoarthropathy results into the severe stenosis that you have at the axial T2 picture that we're looking at. A lot of times people will come see me and just have conversations about, but my MRI is normal, it doesn't show any disc herniation, but the amount of facet effusion that you have over here will give you disc pathology, will give you lumbar radiculopathy. So even though this disc is relatively good, the amount of neuritis that will happen from this facet effusion, it's something to keep in mind. And oftentimes there'll be an aspiration of this facet to make sure you get good relief. But understand that it's not all disc that results into radicular symptoms like sciatica type pain. You could have other pathologies such as a facet effusion that will cause that. Beyond the scope of this conversation, I just want to highlight there are other structures, including ossification of the posterior longitudinal ligaments, as well as epidural lipomatosis that could cause this type of issue. If you have epidural lipomatosis, usually you have this clumping of the nerve roots is one of the radiographic characterization that you have with it. When we talk about stenosis, it could be mild, moderate, or severe. And towards the end of this talk, I will highlight maybe some of the main things to pay attention to when you have a barrage of imaging study report and you're just not sure which one is important, which one is necessary, or which one is a pain generator. I mentioned the synovial cyst earlier, so I would just kind of skip this. It's just a schematic of it, highlighting, more importantly in this scenario, what I showed earlier was the facets effusion here, but a lot of times you actually will have a synovial cyst off a facet that will kind of impinge on the nerve root as well. And so this is what that synovial cyst looks like over here. Oftentimes you could aspirate this facet, aspirate the synovial cyst, or you could actually rupture it by putting some contrast in. But this is a pretty moderate size of a synovial cyst. Sometimes if you aspirate it or you rupture it and it comes back, sometimes a decompression is needed to alleviate the cyst and alleviate the pain. And this is just a few more schematics of that. So foraminal stenosis could be mild, moderate, or severe. A lot of times, when do you know if an MRI finding is most likely to be symptomatic? Oftentimes, if they're moderate to severe, the loss of perineural fat around the nerve root, that's when you know it's more likely symptomatic. I guarantee you, if you get an MRI of 100 of us that are watching or listening to this, we will probably find 40% of us with some degree of stenosis or narrowing or mild impingements. But if they become now moderate to severe, that's when they have a more likelihood of being symptomatic in nature. And so when you look at this particular viewpoint, this is mild because you see the nerve root. So this is a sagittal view. You see the nerve root and you can see the perineural fat over here. As you look at this moderate, there's less perineural fat that you see. And as you look down here, you can't see any perineural fat at all. So that's what mild, moderate, and severe will look like. Moderate and severe, especially the loss of perineural fat in all quadrants, it's more indicative or it's more suggestive that you have that pathology going on. So when I started earlier, I did mention when do you ask to use contrast if you're thinking about infection, if you're thinking about malignancy or post-surgical tissue to differentiate between recurrent disc herniation or scar tissue. Those are the reasons to undergo or ask to get a contrast. Unfortunately, I've seen about maybe 5 or 7 discitis, osteomyelitis, maybe a few more than that. And it's a situation that also obviously needs medical emergency. Sometimes it'll be IV antibiotics, sometimes it'll be a decompression that's needed, but it's got to be under the care of a orthopedic spine surgeon, a neurosurgeon with a infectious disease provider as well too. Usually it'll be increased signal change on T2, and oftentimes on T1, it actually will be dark or hyper intense. But the contrast is what will kind of confirm that. So this is what the schematic or image will look like. On the T1, you can see it's dark, and you can see how it's just very, very focal. If you look at this, you could think that the origin is the disc and a little bit of migration superior and inferior. When you look at this T2 image, you can see the migration over here, superior and inferior. Look at the disc itself or the lack thereof. And when you can see the signal change on the T2. Look at this contrast. You can see how it enhances it a little bit more. So dark, bright, and even brighter when you look at this contrast picture that you have over here. And this is just an axial view suggesting the same conversation that we've said on T1 dark, on T2 very bright. This is what another viewpoint of osteomyelitis, just to kind of get an understanding of it. T2 is bright. This is T1, but it's darker. But when you look at the disc itself, it's a little bit hyper intense when you look at that over here. Post-surgical cases. So you could look at this. This is an L4-5. You see this disc herniation. You look at this T1, there's a disc herniation, and you see this as well too. And so this confirms for sure that this is a disc herniation and it's not necessarily a scar tissue. Let's contrast it to this. Look at this over here on the T1 view. Is the scar tissue, is the disc herniation. When you put in contrast, you're actually able to see that it's not a disc material and it's more of a scar tissue. And so that's the benefit. Several of my surgeons will say, or surgical colleagues that I work with will say, if the surgery is greater than 3 to 5 years, then you probably don't need a contrast anymore. But for the first couple of years, 2 to 3 years, they will recommend that to discern between scar tissue and a disc material. The last few slides, I'll talk about something called Tarlov cyst. Oftentimes is an incidental finding and usually is asymptomatic. Usually is a cystic nerve root dilatation around the subarachnoid space. I can tell several people that I've seen and just swear by it that the Tarlov cyst is the source of the pain. I've seen a handful of people get surgical intervention from this, and most of the time they don't do well because, in my humble opinion, the vast majority of them are not symptomatic in nature. And this is just what they look like. On a T1, it's going to be hypo-intense here and right here. And when you look at the T2, they're going to be hyper-intense, this big structure that you see over here, and this big structure that you see over here. That's kind of what a tall of cyst looks like. So in conclusion, MRI is a peculiar imaging that is often necessarily is difficult to discern between what is symptomatic or not symptomatic. When you're looking at the image or when you're looking at the MRI, have a proper protocol in terms of how to go over those images. Preferably go with A, B, C, D, and E. A starting from alignment is a kyphotic, if it's scoliosis. A referring to alignment to discern if it's a little bit of listhesis that's going on. After you look at that, you go to B, identifying the bone marrow, looking at the bone, evaluating for hematoma, which will be hyperintense on T1 and T2, looking for things like compression fracture, which will be compression or narrowing of the vertebral body itself versus the signal changes that are mentioned in hematoma. Trying to differentiate between T1 and T2, understanding that T1, usually the bone marrow is more bright and hyperintense. And if you start having bone marrow that are darker, is either that's a very younger person, because in that case, their bone marrow could be a little bit dark. But if it's a middle age to an older person, now you start getting concerns of other issues that we're dealing with. As you move on to the canal, you want to think about some of the structures that compromise the canal. It could be a disc, it could be a facet, it could be a synovial cyst from the facet. When you think about the disc, understand the different categories of it. You have an annular tear, which is an interruption of the annular fibrosis structures as it articulates or attaches to the vertebral body. It could be a degenerated disc, which is just the darkening of the disc material due to loss of water, protein, and collagen. You could have a white-based disc bulge, which is usually greater than 50% of the circumference of the disc, versus you could have a disc herniation, which could be divided into more of a protrusion or extrusion. If you have a protrusion, the size of the location that's closer to the base tends to be wider versus the apex of it. Versus if it's extrusion, the apex of the disc herniation tends to be wider versus the base of it. Understanding that you could have a sequestration as well too, where you could have a detachment of the disc materials, not in conjunction to the origin of the disc itself. And we'll move on to E, which I've diagnosed a couple of AAA aortic aneurysm before, several kidney and liver malignancies that's been diagnosed before. Not being shy, just kind of take a step out and see if there's other structures that look abnormal. When you're doing contrast, because most patients might ask, Doc, can we get MRI with contrast? Oftentimes it's not necessary, except if there's a high likelihood of malignancy, high likelihood of infection, or you're trying to discern between a couple of years post-surgery between a scar tissue and disc herniation. In terms of practical pearls to get out of this, if there's moderate to severe stenosis, it can be symptomatic, but not always symptomatic. If it's a disc extrusion, there's a high likelihood that it's symptomatic. If there's a nerve displacement or significant perineural narrowing, it can be symptomatic. Modic changes type 1, which tends to be dark on T1 and bright on T2, usually can be indicative of an inflammatory process. Spondylolisthesis, that's grade 2 or greater, can be symptomatic, but oftentimes you'll see a spondylolysis or grade 1 spondylolisthesis that are not symptomatic in nature. Things that are less likely clinically important, if you have an annular fissure, just some disc loss, some mild stenosis, nerve contact without true displacement, disc bulge, disc desiccation, and facet arthropathy are some of the findings that you will see on the MRI that are usually not as symptomatic in nature. So it's important to make sure you see the patient, get a good history, you do a good physical examination to see what's connected, and get an MRI to confirm the diagnosis, because oftentimes a lot of the findings that you're going to see on the MRI can be asymptomatic and not be the disease cause or the disease generated. And those are my slides. Happy to take some questions.
Yeah, let's see if we have any questions. The chat box has been kind of quiet, so we're gonna just open up the floor for questioning. And if not, we can definitely end this early. But Dr. Olufade, thank you for that was an amazing talk. Thank you for giving us a small synopsis into MRI of the lumbar spine. And as everybody knows, this is just a discussion on MRI, it's not necessarily treatment. Please continue working with your preceptors and attendings to learn the proper treatment. Feel free to reach out to Dr. Olufade, myself, or one of the other attendings if you do want any other information. So we do have one question: is how do you approach someone with epidural venous congestion that is noted on MRI, Dr. Olufade?
Epidural venous congestion. Um, Oftentimes, if I see that, the question is obviously there's a lot of other etiologies that's going on beyond the scope of orthopedic spine or sports medicine. A lot of times when I see that, I would usually refer to my vascular colleagues to take a look. Obviously, those are the scenarios where I will make sure I look for the everything else in terms of aortic aneurysms. I've diagnosed about 5 or 6 aortic aneurysms from the MRI of the lumbar spine. So usually what I would do is I'll take a look at the MRI to make sure there's nothing else vascular going on that's striking to me. And oftentimes I don't necessarily manage that. I usually will refer to a vascular colleagues for the treatment and management of that.
No other questions, so we'll go ahead and end this. We'll go ahead and end this right here. We thank you guys for joining us. I'm Geden Franck. This is Dr. Alfy Olufade, who just gave us an amazing lecture on MRI lumbar spine. Feel free to reach out to us. We're Dr. Olufade, do you want to give us an email?
Sure. If you have any questions, the email is oolufad@emory.edu, and I'll put that on the chat box as well.
Perfect. Thank you for that. Thank you for always being open and available for these talks. And guys, don't forget about the talk next week with Dr. Fredrickson and Dr. Olufade, which will cover bone stress injuries, and all future talks as well. And we hope to see you all at AMSSM coming up. It'll be a great opportunity to convene in person and to talk. But enjoy the rest of your day. Dr. Olufade, thank you, and everybody else, thank you for joining.
Good night, everybody.